So let's see, there was a slide I was hoping to get on there. There was one slide there was an earlier, can you ask there was a slide I just put on, I wanted to just put up before I do this. There's another slide I was hoping he can put up. I just gave it to him.
It's the next slide.
It's the next slide?
Yeah.
Oh, thank you. Way ahead of me. So I added this slide. This is an algorithm slide. Okay. So is that okay? Can't hear me.
There you go. Yeah.
Okay. Thank you. So I put this algorithm together. It's been sort of an interesting work in progress over time, and we've actually now published this. I added this after I saw the earlier algorithm, and it's not perfect, but it speaks to all the different markers. Actually, it doesn't speak to all the different markers. It speaks to the markers, at least in the United States right now, which have met commercial approvability. And there are many more to come. And as you can see, the whole screening controversy is indeed very subjective. And so we get the PSA test, which we've always known is a good test. It's not a great test, but it helps us. Now, the reason the 1.5 is there, and it's arbitrary, but there's some BPH data that suggests if you have a PSA of greater than 1.5 versus less than 1.5, that can be suggestive of worsening obstructive symptoms. One can change that clearly based upon some of the Malmo data that suggests, based upon your age, if your PSA is less than a certain number, then your likelihood of getting prostate cancer is really infinitesimal. The Phi score and the 4K are additional kallikrein subunit PSA factors helping to further guide us as to whether or not to biopsy in the first place or not to. So to biopsy or not to biopsy. Then ultimately the patients would see a urologist, repeat the exam. If you do the biopsy, then you have either negative, indeterminate, or positive. Positive, we talked about the OncotypeDX. There are other tests. Time didn't allow me to give that presentation. There's Polaris, the P10, Tempus-2 ERG, ProMark, which is a protein assay that we're doing some work with as well. Concept there is all of those assays are about better defining indolent versus aggressive disease. No Error is a company that works to provide what's called provenance, or making sure that you don't, you're looking at the right sample. It's actually a buccal swab, making sure that the tissue that you're analyzing and reporting on hasn't been somehow missed in the supply chain, and you're actually, there's true accuracy. And then I'm going to talk about Confirm MDx, and then there's the PCA3. As you can see, when you have a negative biopsy, if you're indeterminate, you could be ASAP, high-grade pin atypia. And then one goes into the interventional strategies, the radical prostatectomy. There's the Decipher test, which is by Genome Diagnostic Biosciences, and the Polaris. And those are helpful in grading and clarity or intensity of treatment in the adjuvant setting. What we're also really working on now, too, is therapeutic response biomarkers, such as circulating tumor cells and other types of compendium diagnostic assays that would tell you if I'm positive for perhaps the splice variant on circulating tumor cells, the ARV7, I may be better selected of giving a chemotherapy versus an oral oncolytic, et cetera, et cetera. So I just wanted to put this up there because this is a lot of the work that I've been doing, and I think it's such a great, exciting time. But again, my disclosures, you've seen this already. The presentation for today now is on what's known as the Confirm MDx, and it's the dilemma of the false negative prostate biopsy challenge. We'll talk about Confirm MDx, when to use it, its validation, and I'll have time for questions. So the false negative biopsy challenge, so in the United States, we do about 1.4 million prostate biopsies annually, and we diagnose prostate cancer in about 240,000 men. I was reading on the internet, I think you diagnose in Israel about 2,400 patients annually. Does that sound about right with prostate cancer? So at least in the US, we have over 1 million patients who have a negative biopsy. So what do we do with those patients? That's the challenge, because about 25% of those patients will have a false negative biopsy. Now, I showed you some of that earlier data in the prior presentation that the Gleason pattern tends to stay consistent with second and third biopsies. But indeed, is there cancer there or not? And there may certainly be that fear in that 25%, which causes us to do repeat biopsies. Now, we're urologists in this room, so we say biopsies, it's not that big a deal, it's okay, I do it, it's like doing cystoscopy, it's not so bad, that's what we do. Well, patients think otherwise, and I'll get to some of that data about that as well. Now, what was mentioned was this concept of cancerization, or the halo effect, and the challenges that we have in the traditional biopsy methodology, whether you're doing a sextant biopsy, or now in the US, we're pretty traditionally doing what's known as this 12-core, right, left, medial, lateral, base to apex, but the needle can miss the cancer. So the pathologist can only report on what he or she can see, and so the thought always was if we're coming in here and we get the tissue that's very nearby this cancer, is there going to be any sort of biomarker abnormality in this halo effect, the surrounding area? This is a paper by Marty Resnick. You might remember his father was the head of the Cleveland Clinic for many years, died a few years ago of lymphoma. But this was done as a cohort study in the University of Pennsylvania. And at least what they were defining as significant was patients who had a high percentage of Gleason 6. It was their own sort of unique definition, anything 3+4 and higher. I believe they had many patients who had 4 or more cores of 12 was considered significant as well. And then this is what they found, at least in their database. But the problem of the undetected cancer leads us to this cycle, this sort of vicious cycle of repetitive biopsies. And so in the United States, and this is a compilation of different data mostly from capture and seer populations, 43% of patients with a negative biopsy will go on to have a repeat biopsy, and of that group, 44% will have a second repeat biopsy. It's interesting how consistent these numbers appear. And so what's the challenge with all these repeat biopsies? The challenge with these repeat biopsies, and this has now been published by Stacy Loeb, who's now at NYU, who had been at Johns Hopkins, looking again at seer data, and I find these numbers personally to be very high. I don't know about you, they seem inordinately high, but that 6.9 or almost 7% of men are hospitalized 30 days following a prostate biopsy. We've looked at our own literature. My clinic is 13 urologists and 3 radiation oncologists and 1 pathologist, and we looked at our data. We're less than 2% with these types of complications, but this is reported in the seer literature. We see bleeding, of course. Infection, if you give prophylactic antibiotics, it seems not to be as bad, but there is more and more quinolone resistance. Sepsis and bacteremia can be rather severe, and one sees some of the other issues here. We're not even really getting into the comorbidities of pain and anxiety and loss of work hours. So unnecessary biopsies are a real phenomenon, both to morbidity of the patient as well as cost. So if we have a negative biopsy the first time, whether it's 8 cores, 10 cores, or 12 cores, can we find an assay and can something be developed that gives us greater confidence that what we did was accurate in the first place? So addressing this false negative biopsy, we want to have something that gives us, again, this emphasis on the word actionable information to improve our risk stratification and how we can better discuss with our patients what do we do next. So we want to rule out prostate cancer-free men from undergoing an unnecessary biopsy. For one, I give a large amount of perirectal lidocaine. I think my technique is very good. None of my patients have pain. Of course, they do. But if I could avoid unnecessary treatments, I think I'm doing my patient a service. And we want to rule in those patients who may still have cancer, who we may have missed in the first go-round. So the Confirm MDx test, it's an epigenetic field effect associated with the presence of cancer, as opposed to the OncotypeDX, which looks at RNA amplification. This is at the level of the DNA. And I'm going to describe to you this concept of methylation, and methylation essentially put, we normally have tumor suppressor genes, and when you methylate tumor suppressor genes, it's sort of it's a negative upon a negative. It's a double negative. By blocking the tumor suppressor genes, you allow for cancer to evolve. So the field effect around a cancer lesion can be present despite the normal appearance histopathologically. And the absence of methylation, when it's not present, is a good sign. It helps you rule out malignancy. The presence of methylation increases the risk for malignancy. So the use of the Confirm DX is for men who've had a negative biopsy, but they have no history of prostate cancer, and they may have some persistent factors that would suggest to you a need for a repeat biopsy. Maybe there is their age, maybe it's their PSA kinetics, maybe it's their overall anxiety. So what is the Confirm MDx? It's a DNA methylation-based assay which measures this halo cancerization or epigenetic changes, which is around the DNA. And we looked at 3 specific methylation markers. And the one that's been clearly the most heavily interrogated is the GTSP1. And this is a measure of DNA detoxification. APC is a measure of prevention of apoptosis. And RASF1 is for cell cycle regulation. It actually correlates with the adhesiveness or the adhesion molecule. The Confirmed MDx does not measure any hereditary genetic predisposition to prostate cancer. So what is genetics versus epigenetics? So epigenetics is really when we look at different gene expressions that can be turned on or turned off by circulating other molecular structures. And it can be microRNAs, it can be exosome formulations, it can be various SNPs. But whatever the causology is, the switch that caused the methylation, it alters the function and regulation of the gene. And in most of these situations, it's tumor suppressor genes, genes that are working teleologically to prevent us from getting cancer. And one can see, and this is not all-encompassing, but when you have normal tissues, a normal an example of an acini of a prostatic epithelium, if you get increasing going from left to right, various markers, one can see the increase in epigenetic markers that are present with high-grade PIN to cancer and metastatic disease. And we've used what's known as QMSP, or quantitative methylation-specific polymerase chain reaction, to also amplify this tissue and allow for evaluation. So where does the Confirm MDx test fit? So much like the OncotypeDX, you don't have to rebiopsy. It's the paraffin-embedded block tissue that you already have. You don't have to do another biopsy. It's the tissue that's already within your pathology laboratory. And you're looking at a man who would be considered for a repeat biopsy. He's had a negative biopsy. You're considering a repeat biopsy. You get the Confirm DX. If it's negative for methylation, all those 3 markers, the GTSP1, the APC, the RASF1, they're all negative. All 3 are looked at each core. Then you could potentially avoid a repeat biopsy. I'll show you the clinical validation study. There's 2 now that give you a 90% negative predictive value. So if all 3 of those methylation markers are negative, it tells you with 90% certainty that your negative is a true negative. If it's positive, it doesn't mean you absolutely have cancer, but it would mean, or to suggest to you to consider a repeat biopsy depending upon your own decision making and further mapping, and I'll get into that in a minute. So this is what the report looks like. And on this report, you see a negative test. So what I tell my patients is that I did your 12-core biopsy. Your PSA maybe went from 3 to 5. You're a 65-year-old man. Maybe he had an uncle who had prostate cancer. He's otherwise in good health. He has no symptoms. He's like, well, I'm worried I'm going to have cancer because my uncle died of prostate cancer. I said, well, we could repeat biopsy you, but I'm going to order this test, and the test has come back negative. And now I can tell you, we talked about that 25% risk of missing the cancer, but now I'm essentially telling you with 90% certainty on my 12 cores that there's about a 10% chance that I could be wrong. 90% likelihood that you have what I showed based upon this cancerization, this halo effect, all the quadrants that we looked at, that there's nothing to be suggestive for cancer. And so this was validated and I'll show you what's known as the Matlock trial and then the following document trial that, and both have now been published, validating and confirming this 90% negative predictive value. Now, you could get a positive result as well. And here you have 2 positive spots, and all 3 markers were positive at the left lateral base, and all 3 in this example were positive at the medial lateral base. Sometimes you'll get one of the markers positive, you'll get both. You don't necessarily get all 3. There is a suggestion based upon the data that the more positivity, the higher the likelihood for finding cancer, as you would expect. But further validation of that in larger studies is ongoing. When I have a patient who has a positive finding that's mapped the way I see it here, and I traditionally do my biopsies like this, these 12 cores, in separate jars. I understand here in Israel you do mostly right and left jars. So there can be, I think, I've talked to the company, I think they can, through working with your pathologist, you can take out the 3, 4, 5 cores per jar and look at them that way, which is more consistent with the validation trials. So these genes and this methylation technology has been reported in well in excess of 45 peer-reviewed papers and probably way now north of 10,000 subjects. And this is not just through the company of MDx Health, but really in many different settings. The DNF methylation has been an ongoing scientific review for over the last decade. Here's the literature that led to the development, and right now in the United States, this particular assay has received tentative approval by CMS, and they have a draft in front waiting for commentary based upon the trials that they've done, and an ongoing prospective clinical utility study that I'm actually the PI for, and I'll show you that trial in a second. So one of the first validation studies was done at Cleveland Clinic and at Johns Hopkins, and basically they did a small number of patients, and this was published in 2011 in BJU, and really showed in a prospective study that there was a 96% negative predictive value, and this was just at academic centers. Well, we've come to recognize it's important that we have multi-institutional studies, that they need to be both in academic and in the community setting. This was followed up by what's known as the Matlock study, and this was published in the Journal of Urology in 2013. Stewart et al. Are the authors, and it was largely done at the Western General in Edinburgh, Scotland, as well as in Brussels. And really what they looked at was a little over 480 men who had a negative biopsy, and they looked at the other factors inclusive of the epigenetic panel, the Confirm MDx. They looked at pathology, digital rectal exam, PSA, and age in a multivariate analysis to decide which had the best performance in terms of prediction on second biopsies. And the negative predictive value was over 90% versus the standard pathology at the time, which was 75% predictive. And looking at an odds ratio, it had the highest odds ratio of 3.17 with a highly statistically significant p-value of 0.0001. So that tells you that gives you independent, significant information on top of those other traditional variables that you would look at. So it improved the stratification that led to a more informed decision on a repeat biopsy, and thus the ability to avoid an unnecessary biopsy. So that paper was Journal of Urology, and now recently a similar confirmatory trial, because this is important to do confirmatory trials, right? We recognize this as physician scientists, and this was just published this year in the Journal of Urology by Alan Parton, and essentially they just validated that Matlock trial. And there's a quote from Jonathan Epstein that was a pivotal validation study demonstrating the test's high negative predictive value and the odds ratio are robust and reproducible in different cohorts of patients. So here is the Matlock trial, which was the acronym multi-center validation study of a tissue methylation assay to predict histopathologically confirmed negative repeat prostate biopsy. And there's the document, and there's the acronym for that. I think when we all come back in our next careers, we want to be the people who come up with these names, because they charge a lot of money to come up with these names for these trials. But here are your clinics that were involved in this second study. So the first study, the Matlock, was European-based. This is now North American, largely just at academic institutions, 350 patients, and it confirms the assay. Here's the odds ratio that I told you, and basically in the Matlock it was 3.17. In the document study, Alan Parton and the academic institutions, the odds ratio was 2.5. So interestingly, it still gives you more significant independent prediction of a negative repeat biopsy in comparison to looking at the things that we normally would view: age, PSA, even presence or absence of high-grade PIN, and even atypia. ASAP, patients were removed. So this study just kind of essentially looks again at the biopsy rate, and especially sees a 10-fold reduction of repeat biopsy compared to the PLCO trial. And one can certainly create, this was recently published in this journal, to look at the reduction in the cost impact factor as well. And when you look at these health economic studies, and more we're recognizing that we have to be more cognizant of this. If you look at not only the cost of the physician and doing the biopsy and the pathological interpretation, but if one adds on any of those comorbidities, hospitalization for sepsis, a hospitalization or prolonged antibiotic course, or recurrent visits for pain, etc., or bleeding, or the occasional but rare complication for transfusion, that really adds to the economics of unnecessary repeat biopsies. So patients with previous high-grade PIN or a negative biopsy are eligible. You can get and go back retrospectively and look at patients within the last 2 years, because both the Matlock study and the document study looked at patients with a 2-year look back as well as going forward. You need a minimum sampling requirements, a bilateral sextant, though traditionally you can do this with 8 cores. So that's just, could you do it with less? Sure you could, but the studies were based on an 8-core minimum. Like the OncotypeDX, it's only a very small amount of tissue, about 20 microns in the frozen fixed paraffin embedded block of the cores that you've obtained. And you can be on an unstained slide or in the paraffin block. So now we're doing this Pasquale trial, and we had prostate assay specific clinical utility at launch. And we're really accruing really well for this. I think I don't know that we'll have, we won't have anything ready for this year's AUA, but there's a small chance we may, but I think it's going to be too tight for late breaking. But we'll certainly have something for next year and possibly for EAU. So we have 15 sites in the United States, 600 subjects. The primary endpoint of the study is a reduced rate of repeat biopsy in the Confirm MDx negative case arm. So what does that mean? Here's the trial design, 600 patients. They get randomized basically one-to-one. Patients will get the assay or they won't get the assay. And initially when they make their decision about going forward with a repeat biopsy or not. And then even the patients who are blinded to the assay's results will ultimately see what would have happened if they'd received the assay. So what we're really hoping to show is at least somewhere between a minimum of a 20% reduction in the risk of unnecessary biopsies. And one can see that this is the methodology that's being put forward now, and I was talking about this earlier at the break, to what's known as the Molecular Diagnostics Program in the United States. And this is the primary format for getting a reimbursable code. So here's what, here's a case. Patient had 2 previous negative ultrasound-guided biopsies for high PSAs. He's shown to have positive disease in this one particular area, and then he ultimately gets rebiopsied and gets saturated on that side. Now, I will tell you, in all fair disclosure, the cancerization effect can sometimes be, it's not a one-to-one correlation when you go back and do the biopsies and find them there. You may find still disease on the contralateral side, and that may be partially because of the way we do our biopsies, the deflection of the needle, and sometimes we're putting it where we think it goes and not necessarily where it actually does go. But that said, if I have a positive finding, I don't regularly routinely biopsy everybody reflexively. It would depend upon the age of the patient and my other concerns for a repeat biopsy, their PSA kinetics, family history, etc. So in summary, the Confirm MDx, it really is something that you can use to improve your risk stratification very simply for doing a repeat biopsy or not. It's not to exclude a first-time biopsy. It has a 90% negative predictive value for reducing unnecessary biopsies, now validated in 2 large clinical prospective trials. The methylation has been proven to be a most significant predictor for cancer detection on repeat biopsy, and the GTS-Pi1, the RASF1, and the APC have been methylation markers that have been amply studied into 2 decades now. Why do this? To try and reduce patient morbidity and healthcare costs and ultimately patient outcomes. Thank you.